All right, if you would all flip to the EKG on page 27.
But they, yeah, the editor.
What do you think? Good. Inferior wall injury. Everybody look at 2-3 and AVF. Very classic pattern. If you look at the ST segment, it doesn't have a concave contour. It's more flat. We have a very symmetrical T. Reciprocal change is very predominant in 1 in AVL, which we see. Plus, we also have it in our precordial. So there is information here, and if you look at the interpretive algorithm, which I've uncovered for you, it says acute MI suspected, inferior infarct, possibly acute. So see, you're just as smart as the device. Anybody have problems with that one? All right, how about the one on page 28? First of all, we have somewhat of a messy EKG. Would you all agree? We've got a wandering baseline. It looks like we've got maybe some artifacts here that could come from muscle tremor. If this was creating a problem with your interpretation, you would redo it. Try and clean up the signal. Figure out where it's coming from. Do I have a TENS patient? Are my patches on? Are my patches good? Or did I get them out of a pouch that had been sitting there for 3 years and the gel was dried out? Did I prep the skin appropriately? And in the next module, we're going to talk about that. But it is what it is. We're going to work with this one. What do you see? Good. Antral septal injury. Look at V1, V2, V3, a little bit in V4. Do you have reciprocal change? Look at lead 2, flat ST segment depressed. Kind of hard to tell because you've got the wandering baseline, but AVF, flat ST segment depression. Reciprocal change. More subtle, but it's there. And as we look at the interpretive algorithm, again, stamped as an acute MI, consider anterior injury or acute infarct. How about the one on page 29? Good. I heard inferal lateral injury. Inferior grouping, plus you have it in your lateral views. Up top it says inferal lateral injury. Who can tell me what rhythm that is? It's a paced rhythm, isn't it? But this isn't a normal paced rhythm that you're used to seeing, is it? This pacemaker is attached to the atria, not the ventricle. So we have a pacer spike before the P wave. So it raises question, does that affect my interpretation at all? It doesn't. If it was a paced ventricle, then I would have concern because that caused distortion. But the movement of electricity through the ventricular region is not affected because the pacer wire is attached to the top of the heart. So while I make note of that, this inferior wall presentation plus the reciprocal change along with it stands to reason. Makes sense. And how about the one on page 30? indicative change? Yes, we're at. Good, look at V1, V2, V3. V4 doesn't look too bad, but are these anatomically grouped? Yes. We're looking at an anteroseptal injury. Here's our reciprocal change over on the other side. And that's exactly what it says.
So even though you don't have continuous with V3 and V4, you still call it septal?
Yes. So even though V1 and V2 are septal leads, this is one standalone. Think about for V1, V2, and 3, they all sit next to each other.
Right.
Now, as I do serial EKGs, is it possible I may start to see this transition into V4? Yes. That's why it's important to do ongoing tracings with your patient, not just one, because it may change along the way.
So as long as you have it next to it, because they're
Yes,
they're contagious.
correct. Now, if I had elevation in V1, normal, normal, this one's, now those aren't anatomically contiguous because they're not in the same area. But if they're grouped together, yes. And then how about the one on page 31? Thoughts? Good. High lateral infarct. Why do we classify it as that? Look at leads 1 in ABL. Dramatic change. But if we choose our other lateral views, V5 and V6, which are in the low plane, those are not elevated. So we have a high lateral infarct. And if I wanted to look for reciprocal change, where would I look for it at? Right here. And that's exactly what you have. Looking at the algorithm at the top, consider lateral injury or acute. Questions with that first section? Everybody's good? How many of you learned something new out of that first section? Well, that's a good thing. That's always promising. All right, give me a second. I'm going to transition over to the next part. All right. This module is somewhat shorter, but there's some very important information when it comes to acquiring a 12 lead. And then, of course, specific to our EMS partners or colleagues, how many of you are actually transmitting EKGs in the field? Excellent. Okay. So we'll talk a bit about that as well. So our acquisition goals, I would think you would all agree with me that we want to make sure that we're trying to get a clear, very accurate tracing, and let's face it, we want to do it as quickly as possible. We know that's not always possible. Think about your winter months, where patients have layers and layers of clothing on, or let's talk about the female patients, who now we have to worry about maybe a bra that's on. And it's very difficult sometimes to get to your patient's chest. Now, some of you probably are not familiar with this. You know, I come from the era where we never did 12 leads in the field. All we did was 3-lead monitoring, 3-lead monitoring. So when the 12 lead came into the pre-hospital setting in the early 90s, that was a dramatic change for us. And one of the concerns back then was, this is going to take too long. Why are we doing all this? It's not really going to give us additional information. Why are we wasting our time? But EMS systems adapted. And since we do things simultaneously, now we can acquire a 12 lead very quickly, and it hasn't affected scene time, and it actually gives you great information about your patient. So it can be done, and most of you are in the realm, you're already familiar with it because you've been doing it since day one. So I want to talk a few minutes about frequency response. Okay, remember I told you your 12-lead device is a voltmeter. It measures electrical activity within a certain parameter. Now, when you go on runs or you're monitoring patients in the hospital and you put the wires on and you just want to do rhythm interpretation, you want to see what rhythm they're in, most often monitors are in what's called monitor quality. So if we look at the whole spectrum of everything that's picked up, monitor quality actually is a small section of that. And the reason it's finite to that is it cuts out all the other stuff that we don't want to see. Skeletal muscle interference, 60 cycle interference, muscle tremor, wandering baseline. The problem is when you put it in monitor quality, guess what? The ST segment, you can't adequately evaluate it because it's at the low end of the scale. So when you do a 12-lead on a patient, this window opens up and encompasses everything. And that you probably already understand that when you acquire a 12-lead, it's very important to have your patient remain vitally still during that 10-segment acquisition period. And that's the reason why. Because you've opened up the window to allow all that frequency to come in, and it may disrupt your EKG. So the thing I want to point out to you here is 0.05 hertz on the low end. That is classified as diagnostic. Okay? 0.05 is diagnostic. It really doesn't matter what the high end is, because the ST segment sits right here at the low end. So in monitor quality, you will not see this at 0.05. The low end typically is 0.5 to 1. That is not low enough. Okay? Now, why do I care about all this? When you hit the 12-lead button on your device, the frequency window is changed for you. The reason I'm bringing this up is, especially for my EMS colleagues, depending on what device you're using, when you're going out and doing your 4-limb lead monitoring, when you hit the print button, do you know what frequency your device is set up for? It's worth checking, because if you're trying to do ST segment evaluation while not doing a 12-lead, just when you're doing a lead to interpretation, you can't do it because it's not in the right mode. So you have to know what you have before you know where you can go. Here's what diagnostic quality looks like. The window is way opened up, but it opens it up to all that stuff that we don't want to see. We have a bigger window, and again, some devices will limit the upper end to 30 to 40 range. Doesn't really matter. What's important is the low end of the scale. So how do you know what your frequency response is set at? Look at the bottom of your EKG paper. It will tell you. Okay? It will be stamped in the lower left. So on this top one, and I don't think you have this in your handout, it says 1 to 30 hertz. That is monitor frequency. Down here, 0.05 to 150. That's diagnostic frequency. 12 leads have to be done in diagnostic mode. So diagnostic quality, we know that it opens it up and it's more sensitive to artifact. So how we can improve the signal that we're getting, that we can have good representative complexes to look at. First thing is we have to start with skin prep. You have a guy with a hairy chest, or even a woman that has a lot of oils or lotions on her body, we need to do something to clean that off so we can enhance the signal. And this is one of my pet peeves in the field. I don't think we go far enough when it comes to prepping the skin. In the pre-hospital setting, as well as in a hospital setting. We're just basically plopping patches on patients, trying to capture a picture, and lo and behold, what happens? Those patches start to peel off. It reduces your ability to get a clear signal. If you spend the extra few seconds on prepping the skin, it's going to make your job much easier.
Hey, Brent,
Yes?
so it's just cleaning the area, shaving, cleaning the area, what about like the benzo sprays that are out?
The what? I'm sorry?
It's like a sticky spray that I've seen some places use, it's a brown, I think it's a benzo spray.
That's the one I'm not familiar with. I will tell you, years ago, and maybe Barbara remembers this trick, a lot of EMS agencies used to carry Arid Extra Dry antiperspirant because it did an excellent job of stopping diaphoresis in the area where you're putting your patches on. The only problem, it had a lot of talc and powder in it, and if you really coated the skin, that actually reduced your ability to capture a signal. But that's still a trick that can be used. That stuff might work. I'm not that familiar with it. So when it comes to removing hair, there are nice devices out there, rechargeable clippers with disposable heads. And again, you don't have to shave the whole chest, just in the area to where the patch is going to go. And then skin prep is vitally important. Who here has had a stress test done before? How do they prep your skin? Doesn't feel good, does it?
No.
By the time you're done, your chest is red. I've even seen in old scenarios where they've used sandpaper, where they will actually take your skin oils off, they will scratch the neck surface down. And the reason they do that is they want to make sure that that gel will seep in and adhere so we can isolate just the cardiac signal. Your patches, when they're appropriately patched, are only picking up 20% of the electrical flow that's emitted from the heart. That's a very small percentage. So anything that we can do to enhance that signal, we need to do it. I'm sure you've all encountered this. Critical situations, you're trying to put patches on, by the time you hit the 12-lead button, the patches are peeling off. We need to do a better job with prep. Some other causes of artifact. We've got a lot of things hanging off of our patient. All the wires coming from your device, automated blood pressure cuff has its own tubing, pulse ox cable, you name it. And you've got all those wires laying on top of each other, blood pressure is being acquired while you're trying to acquire a 12-lead, that's going to produce artifact. Electromagnetic interference. Think about anything that's surrounding the patient. An electric hospital bed, an electric lift chair in someone's house, a refrigerator, a cell phone, potentially can cause interference. Sometimes it's hard to isolate where it's coming from, but we do our best. We try to make our patient as comfortable as possible. Ideally, a 12-lead is supposed to be acquired with your patient in a supine position. You all know that's not very easy to do, especially if you have a symptomatic patient. So semi-reclined is fine. However, when you get your patient in a bolt upright position trying to acquire a 12-lead, what's the issue with that?
Would be the
It's
wires.
not, say again?
It's the wires.
It's not so much the wires, but think about it. As you go from a lying flat position to sitting upright, what changes is the position of the heart in the chest. There's movement, not to mention the overlying skin. If they have adipose tissue, that's going to move as well. So your positioning for picture taking might be off. Now, I realize we do it, and I understand why we do it. It just makes more difficult to get an accurate picture. So supine is preferred whenever possible. We have to make our patient as comfortable as possible. Anything, slight movement from your patient during that 10-second acquisition period can cause problems. If you've got your patient on the cot or the bed and you're watching what you're doing and they've got a death grip on the rail, tension in the arms causes tension in the chest. You're going to see it on your EKG. Or if you have a patient that's kind of lifting their head off the pillow or off of whatever they're sitting on to look at what you're doing, tension in the neck is tension in the chest. So we try to get them relaxed for that short 10-second period. Again, watch the cabling between your monitor and your patient. And can you acquire a 12 lead in the back of a moving vehicle for my EMS people? Sometimes. If you're on a nice stretch of highway, nice pave, not too bad. If you're on a road with a bunch of potholes bouncing up and down, you might as well forget. I don't know if you know this, but the pre-hospital devices that you carry actually have built-in filters for excessive movement. They're built that way, but they don't always work depending on the roadway that you're on. And then think about electromagnetic interference. Interference from anything that might be surrounding your patient. A number of years ago, I was speaking at a conference in Denver. And I kind of got to know the providers in the Denver area fairly well. So one time I was there, I was at my hotel. They asked me if I wanted to spend some time with them riding in the street, which I did. And they ended up taking an interfacility transport, which ended up being a lot longer than I thought it was going to be. 4 hours into this, we had to take a patient, go out from a rural facility and bring them back in. But it was a patient that needed to be externally paced during transfer. And normally they don't do it that way, but this rural hospital didn't have the ability to put in internal temporary paces. So back then we were using a LifePak 10. We were externally pacing the patient, and we had the patient very well sedated, and we're on the way, and all of a sudden the pacer shuts off. And we're all looking at each other trying to figure out why this thing isn't working. So we're trying to troubleshoot it. There wasn't anything wrong with the device. It was attached to the patient and everything. Started working again, everything's fine, and then a few minutes later it shuts back off again. And what we found out was the person that was driving us was using a cell phone. And every time they would engage with that, it would shut the pacer down on the LifePak. I'm not saying that's a common occurrence. I'm just saying there are things that can cause interference. Just look around and maybe you can isolate what it is. Some other things to look for in a clear EKG. Again, this isn't in your booklet, but just look up here. What do you think the problem is here? Patient movement, right? How about this one? Muscle tremor. Patches that are dried out. Patches placed over bone instead of nice meaty areas of the chest. That's why we have to be very good at our patch placement. Some other things when it comes to accuracy. We're going to talk about each one of these individually. We'll talk about lead placement. Ideally, limb leads should be acquired from the limbs. Again, I realize in a pre-hospital setting, sometimes we can't do that. We tend to centralize up to the torso. That may throw the picture off slightly, but it serves our purpose, especially when we're trying to move our patient constantly. If you put them out on the limbs, it makes it very difficult to do the work that you need to do. We already talked about when you validate your EKG, AVR should be negative. It tells you if your wires are in the wrong place. And then how many of you have this committed to memory as far as where your patches go? So I think you all know that V1 and V2 have very specific spots. So does V4. And then we kind of fill in the others. Here's my major problem. So years ago, we had toyed with the idea of going to, and I'll just call it a unipatch. It's a strip that has all your patches in it that we would universally put on a patient and get the patches in the right place. So before we started looking at moving to that, we tried a little drill with some of our providers to see how well of a job they did with putting patches on a patient's chest. So we brought in models, males as well as females. They bared their chest. We had the providers put on the patches like they normally would in the field, and this is what we found. So look at our guy on the left here. Here's the sternum. V1 and V2 are supposed to be along the sternal borders. You know that V1 is out of position. And then when you look at V2 through 4, we know that V3 is supposed to be between V2 and V4. Is it here? It is not. It's way off. Now we look at this one. Again, V2 through V4 should be a straight line. I would imagine right now, when you go back to work or wherever you're at, this happens every day. We have to do better at our patch placement. If the patches are not in the right place, if the skin is not prepped, you're not going to get an accurate picture. Here's that patch I was talking about. We ended up not moving to this because we had more problems than benefits to this. It was my understanding at one time that St. Luke's was using these for a while. I'm not sure that they are anymore. But there were guides on the device itself to get it centralized to the sternum, and then these patches would slide horizontally to get them in the right spot. And it was actually more work than it was work. So you may come across something similar to that as you navigate out there. So we talked about negative AVR. We want to make sure we've got a good cardiac cycle that we can look at. We already talked about diagnostic frequency response. Paper calibration. Years ago, I was working with a partner in the field. We had a patient, we had the 12-lead hooked up, and before we could hit the print, my partner says to me, hey, this guy's having a huge MI, I can see it on the screen. The thing I want to pass on to you, your scope or your screen on your device is not diagnostic. Your scope or your screen has built-in distortion to help your eyesight. You have to go off of a printed EKG to look for ST-second deviation. Screen doesn't do it for you. Okay? Frequency response, I already talked to you before, stamped in the lower left. Calibration, you probably have never paid attention to this, but in each row, you see a calibration impulse. So when you hit the 12-lead button, your device will automatically calibrate itself before it acquires the 12-lead. And typically, a 1 millivolt impulse should generate a box that encompasses 2 big boxes in your EKG. In all the years I've been doing this, I have never seen a device not calibrate correctly. But if it does fail, it's going to give you a signal. But that's what this impulse is. And you always see a ×1 down here because ×1 calibration is standard for 12-lead acquisition. Paper speed. In other words, once you hit the 12-lead button, the way that comes spitting out, it's at 25 millimeters per second. You have the ability in most devices to change that. You could actually speed up the paper to 50 millimeters per second. Why in the heck would I want to do that? Is there a reason? I heard it.
Heart rate was too fast.
Heart rate issue. Let's say I have a patient in SVT, or what I believe is SVT, rated 260, 270. Is that possible? Yes. That was me. I had SVT rated 270 a number of years ago. Is it truly SVT or is it AFib? Well, the way you can tell is speed up your paper speed and it draws your complexes farther apart so you can appreciate the underlying baseline. We don't often do it in the field, but you have the capability to do it. And your paper speed is always stamped at the bottom also. So when do we acquire an EKG? Again, this isn't in your handout, but you just look up here. Same patient, 2 EKGs, 12, 14 minutes apart. Any problems with the first one? What happened with the second? All these very gross, obvious changes, huge infarct pattern, where did that pattern go? Can that happen? And the answer is yes. Just as symptoms can wax and wane, so can EKG signs. Going back to my early statement today, 112 lead does not a trend make. So you arrive on scene, you get to the patient, you acquire this, 10, 15 minutes later it looks like this. What happened? Is the infarct gone? Not necessarily. You build a story over time with your patient. What's vitally important for my EMS people here, let's say you get there and I acquire this, it lasts for a few minutes, the next 20 to 25 minutes, I'm looking at this. You get the patient to the hospital, doctor comes walking in, well, that's a normal EKG. And then you show them the very first tracing, now their suspicion is much higher. You gotta share the transition of the story over time. It's part of the patient's not only history, but also where their treatment needs to go. Let's talk about therapy for just a few minutes. We assess and treat simultaneously. As we find things, we may deviate from our plan of treatment. And I think most of you are all familiar with Mona greets all patient, morphine, oxygen, nitroaspirin, not necessarily in that order, but that's our standard ACS therapy. So when it comes to acquisition, we have to have access to the chest. Hospital, it's fairly simple. They disrobe the patient. They put them in a hospital gown. They have free access to the chest. Pre-hospital setting, not as easy. Although in some places that I've taught, many of the EMS transport agencies are now carrying hospital gowns in their trucks. So they will disrobe the patient from the waist up, put them in a hospital gown, and it makes it much easier to get to their chest. You guys could do that if you wanted to. You have access to sometimes the linen at the hospital, so you can carry a couple in your truck, and it makes it much easier. Allows for a better complete exam, doesn't allow for wire entanglement. Let's face it, if your patient should happen to arrest on you, you've now got quicker access to their chest. And then briefly, I want to talk about transmission. When we first started transmitting years ago, common complaint was, well, why am I wasting the time? I've got a short transport time. They're going to know what I have when I wheel through the door. How do you argue against that? Even if you're across the street from the hospital, is there value in transmitting the EKG? Yes, there is. Early notification, the earlier the better, because we're talking about speeding time to treatment. You're all familiar with the door to balloon time. Now it's first AKJ to balloon time. They're monitoring all these time parameters that are all of benefit to a patient. I was reading a study a number of years ago. They identified 14 different areas of delay from the time the patient started experiencing symptom until they actually have definitive care provided at the hospital. Ranged all the way from patient denial of symptoms to everything in between. EMS was in there, hospital was in there. So anything that we can do to speed time to treatment is a huge benefit to your patient. Transmission does make sense. Questions on that second module? Very quick, nitty-gritty, nice to know stuff. For the guys and the girls, do you all feel comfortable acquiring an EKG on a female patient? For the most part?
This is if you put in how big they are here.
Okay. we always try to maintain their modesty whenever possible. I know it's difficult. You know, if you have a female partner or a female in your crew, sometimes it might be easier. But certainly with gloved hands, you want to use the back of your hand as opposed to grabbing with your fingers. I mean, these are just common sense things. And I realize it's more difficult. It is. But we have to do our part because we're there to make sure that we're doing the ultimate best for our patient. Any other concerns as far as acquisition goes? Yes?
As far as the limb leads, instead of putting them on the central location like you talked about, you prefer them being actually on the limbs?
Again, the gold standard is they should be on the limbs. That's where they're designed to be. The reason we've centralized them for the pre-hospital environment is it makes it easier for you, number one, and because we're constantly moving the patient, if you put them out on the limbs, you know what happens. It gets entangled on something, they get ripped off, and it makes it very difficult. While the picture may look slightly different, for the most part, it's going to get you what you need in the emergent setting, so you can, something you can work with to notice whether something's wrong or not. So while it's not ideal, it does work in this setting. Other questions? Yes?
On the primary four leads, what's the best placement when you're putting them on the body? I mean,
So her question was the primary four leads as far as the body. We always taught in Lucas County creases and crests. So on the arms where they attach to the chest, here's my crease. So we want them just above that and in. So we want it on the median area of the chest, not on the bone. And then crests, find the iliac crests, we come up and then slightly in. So we want it here. We don't want them on the belly because if you have a belly breather, their belly's going to float in and out. So we try to keep it lateral. So if you kind of take that approach, it makes it a bit easier. Any other questions? These are all great questions. All right, let's move on to module 3. Let me give me a second here to flip over. All right. If I were to ask you right now, and some of you may have already looked forward in the book, if you could define for me what an acute coronary syndrome is, what would you say?
Signs and symptoms consistent with cardiac ischemia.
Signs and symptoms consistent with cardiac ischemia. Anybody else? One thing that I recognized throughout the last probably 15 years, I don't know if some of you may have picked it up or not. When I used to see commercials on TV related to heart attacks, they always talked about chest pain. Hey, if you're experiencing chest pain, and they would talk about how that chest pain would evolve. They don't talk about chest pain anymore. Now they talk about the ACS symptoms, acute coronary syndrome, because it's not always just about chest pain. It's about a whole other factor and a whole other presentation. So we've seen a transition occur with the education as well, making sure that we have a very important understanding of what ACS is. So by definition, the acute coronary syndromes are acute, sudden onset of myocardial ischemia. So they're sudden ischemic disorders of the heart. They include unstable angina as well as acute MI. And they represent a continuum of a similar disease process. And what complicates it for all of us is the timing. Time tells the tale as to whether this is going to be an unstable angina patient versus a patient that truly is infarcting their heart. That's our challenge. So there are 3 acute coronary syndromes. Here they are. Unstable angina, a non-STEMI or N-STEMI, and the one that we have been talking about all morning, the ST segment elevation, myocardial infarction. These are indistinguishable within the first several hours. That's our problem. You can't tell them apart. So if you can't tell them apart, what do we need to do to help identify what's going to happen to a patient? Trending of EKGs, monitoring of symptoms, watch for evolvement over time. That's going to help you. Sometimes the picture is clear, sometimes it's not. So the acute coronary syndromes all have the same initiating events. All have sudden ischemia, can't be differentiated within the first several hours, and they all have the same initiating events. And here are those initiating events. There is a plaque that ruptures, there is a thrombus that begins to form, and to some degree there's vasoconstriction of a coronary vessel. So I've given you these nice colored pictures to look at in your book, and I want to start here. If we had the ability to do a cross-section of a coronary artery, and we made comparisons between a stable vessel versus one that's very vulnerable and susceptible to plaque rupture, we make comparisons between the two. So let's look at the stable one first. You all know that the inner lumen, this is where blood flows. You have a muscular cap that goes all the way around. And as we progress through life, fatty deposits, plaques, begin to build up in our vasculature. I hate to say it, but it happens very young in life. And depending on what your lifestyle is, some of us develop this at a faster, much more abundant rate. And most of us, probably in our early education, were taught that those fatty deposits would build up on the inner lumen of the vessel. That is not true. They're actually stored within the muscular wall. And in most patients, if they're stable, they have this nice, thick muscular cap that holds it in check. Now let's look at a vulnerable vessel. Patient with multiple cardiac risk factors, poor lifestyle, sedentary lifestyle, obese, overweight, doesn't exercise, family history. Notice the difference between this two. While the lumen itself is much larger, what's compromised is the fact that the muscular cap that holds this lipid core in check is almost non-existent. It's very thin. And over time, that may get inflamed. And when it becomes inflamed, it ruptures. Now we have this fatty content in plaque coming in contact with free-flowing blood. Your body senses that as an injury and does what? Starts to fix it. So platelets start to adhere to that. The clotting process begins. So depending on how big this rupture is, you may see these platelets adhere at a very quick rate. And over time, that's the formation of our clot. What's a great drug that we can give to patients while this is happening that helps us out? Aspirin. Aspirin is an antiplatelet. Now, I know this isn't something you guys want to think about, but any one of us in this room right now, you may have already had this happen to you. You may have had a plaque rupture, You may have had a thrombus that was beginning to form and you didn't even know it. Because guess what? Your body fixed it all by itself. Maybe you had a very small tear, a very small rupture. Your body has the ability to lyse this clot all by itself. Obviously, the patients that are more compromised, high comorbid factors, other things going on, their body doesn't respond as well, and this continues. So we can help out the scenario very early on by giving antiplatelet therapy, and it's very effective. Now, over time, as that clot matures, the next thing that happens with the clotting process is fibrin strands start to form. That solidifies that clot. Years ago, there was patient-centered therapy that worked directly on these fibrin strands. Anybody know what it was? Thrombolytics. Clot-busting drugs. Thrombolytics or fibrinolytics work directly on fibrin strands. So if a patient came in, they were symptomatic, certain time frame, they would give this clot-busting drug, it would break up these fibrin strands and dissolve the clot. Now, thrombolytics have somewhat fallen out of favor over the last number of years in preference of, let's just take them to the cath lab and figure out what's going on. And then lastly, while all of that's going on, the clot forming, fibrin strands, because that vessel is injured, it starts to constrict down. Makes it much smaller. What's a great drug that we can help out with that? Nitro. Nitro helps with vasospasm. So while most departments didn't carry thrombolytics in the field, hospitals can get it. You have two great drugs early on that are beneficial to an ACS patient. Antiplatelet therapy and aspirin, as well as combating vasospasm with nitro. It makes sense. So here's the $64,000 question. All the acute coronary syndromes start the same way. Plaque rupture, thrombus formation, vasoconstriction. Will that patient end up actually infarcting their heart? Will they have tissue death? Every patient is different. And here are the variables that kick in. Number one, how bad is the plaque rupture? Is it some little tiny thing that the body can help by itself? Or is it some massive fissure? Number two, how well is that thrombus now formed? Was there a delay in calling help? Is it now more fully matured? How bad is the vasoconstriction? Some patients will have very severe vasospasm, yet others only a moderate amount. What's the oxygen demand on the rest of the heart? Hey, let's say we've got an inferior wall injury, inferior wall is affected, but what is the anterior wall doing to make up for that compromised tissue? And then lastly, how good is that patient's collateral circulation? You all know what collateral circulation is, correct? Who can define it for me? Okay.
It's when vessel gets included and the body naturally produces different pathways for blood to flow.
Okay. You see extension of other vessels around the area to feed in for that compromised area. Here's the question though. How quickly does that happen? It's immediate. Collateral circulation begins immediately. It doesn't become fully formed for some time. Here's the other compromising fact though. If I have a 30-year-old patient with no comorbid factors, no risk factors, versus a 70-year-old with 3 past MIs and a whole bunch of other problems, who has the better collateral circulation? A 30-year-old. Okay? Every patient's different. So you guys should be familiar with the 3 I's. Ischemia, injury, and infarct. So we're gonna define those real quick for you here. So if we had looked at a cutaway of the left ventricle, and let's say everything's working as it should, everything's working fine, you got good blood flow, good electrical signal, we're relying on a skin sensor placed on our patient's chest or arms, looking in at the activity, and if electrically everything is good, your EKG looks phenomenal, nothing wrong. Now let's change that scenario. We have a plaque rupture, we have thrombus that's beginning to form, and we have vasoconstriction. Now, everything distal to that site, I've got colored blue, which means there's a lack of blood delivery and oxygen delivery. I think you all know that as these fat epicardial arteries come down, they bifurcate off into very small sections and they feed the inner wall. So if there is a blockage right here, where the heart feels the pinch first, is not on the outside, but on the inside. It's kind of like feeding your yard. Let's say you're trying to water your yard, you have a very big yard, and you've got hoses laid out all over the place. If I pinch on the proximal end of the hose, where is it going to affect or do the most damage? It's going to be on the most distal section of that hose. Same thing in the fire service. So if I put the pinch way up here, where the heart's going to feel it first is here, internally. So ischemia is classified as, here's a fancy term for you, subendocardial. Ischemia begins on the inside of the heart first and works its way out. So as we electrically look at this change, that ischemic change subendocardially shows up as J-point and ST segment depression and T-wave inversion. So ischemia we know is inadequate oxygen in the tissue. It's subendocardial in nature, usually represented by J-point ST segment depression, T-wave inversion. The question is that person infarcting? Can we answer that question? They're on their way.
Really, it's just ischemia, correct?
Pardon me?
It's just ischemia, that area is ischemia.
Correct.
That's what we're seeing.
So when you think about injury, which is the next thing we're going to talk about, guess what the definition of injury is? A prolonged ischemia. So they're actually both ischemic events. One has just been going on longer than the other. Because eventually, that ischemia is going to be full thickness of that muscle. Those cell walls are going to start to break down and become injured, leak their cell contents. It's going to be detectable in blood, and we're going to see a transition on the EKG. So I want you to look at the EKG on page 7 for a moment. Take a look at each one of the leads, and there should be something that stands out as being abnormal here. What is it? We do have a funny looking beat in the kind of midstream here. Take a look at the J point and the ST segments on many of those lead views. The ST segment is very flat, doesn't have a normal concave shape to it, and they are depressed. That's a sign of ischemia. And we've got it in multiple leads. And if you look at the interpretive algorithm, marked ST abnormality, possible inferior, there's that fancy term, subendocardial injury. This is a ischemic change. So here's the question. Is this person infarcting? It's not a STEMI pattern that you're used to, but this is the process in play in front of you. What we do over the next minutes to hours can dramatically impact this patient. We know what this signifies, we know what this means, we put it together with a patient presentation, and we define a better treatment plan, which we'll talk about here in a little while. Does everybody understand that, for what I'm talking about ischemia? Now let's talk about injury. Remember I told you ischemia started in the middle, this goes on for a long period of time, now full thickness. That's the one that we're traditionally used to looking for. Injury pattern. J-point ST segment elevation, anatomically grooved. There's the fancy term they use is transurethral. Full thickness. Long-term ischemia, and that's the one that ends up looking like this. J-point ST segment elevation, anatomically grooved, reciprocal change, and the stamp of acute STEMI at the top. And then lastly of the three I's is infarct. Defined as death of tissue represented by pathologic Q waves. Just know that all infarcts don't always give you pathologic Qs. Used to be in years past, prior to the time of coronary care units back in the 50s and 60s, the way that you were diagnosed with having a past MI was the development of a pathologic Q on your EKG. Not really used in today's world. Because now that we're speeding patients to treatment, even though they've had an infarct or a process of infarct, many patients never develop pathologic Q waves anymore. So it's not common with all patients. So as this tissue dies off, it becomes electrically silent, electricity bounces off of it, and it shows up as a negative Y complex. So look at the EKG on page 11. I will tell you that there's no current ischemic event here. That there is evidence on this EKG of 2 previous MIs. Who can tell me where they're at?
Anterior.
Why do you say anterior?
It's the R wave progression's completely obliterated.
There you go.
Predominant negative deflection.
Good. So going back to what he said, if you look at the R wave progression in V1 through V3, it stays predominantly negative. You actually have a QS pattern, it's Y. So here's an old antral septal injury, and then there's one more. Where is it? Take a look at leads 2, 3, and ADF. What's wrong with those leads? They should be positive, right? We have a Q wave significant in 2, 3. Here's an old inferior infarct. Okay? This is where you might see up in your algorithm, inferior infarct, age undetermined. Antral septal injury, infarct, or age undetermined. Again, if you did pick those up, not a big deal. But there's information here worth having if you know what to look for. So when it comes to ACS, we want to make sure that we can rapidly identify these patients so we can begin treatment. And I told you before, your patient's story is very important. Evaluate risk factors, and then we couple that together with our patient's EKG. So what I'd like to do for just a couple minutes here is talk about the different presentations that you see. And there are 3 subsets of symptoms that are important. classic anginal chest pain, atypical pain, and your anginal equivalents. Now, you guys already know this. The classic anginal chest pain described as central dull pressure, elephant sitting on my chest, belt across my chest, squeezing of the chest, radiates to the jaw, the shoulder, the left arm, associated with nausea, vomiting. That's a classic presentation. Here's the problem.